My 64-year-old uncle developed a case of pneumonia when he first started noticing dyspnea, exhaustion, pyrexia, a moderate case of tussis, and sporadic rapid breathing. This led to a case of syncope, and he was on the floor for at least 6 to 8 hours. When taken to the hospital, the doctors noticed a high fever and a normal CPK level. A GFR test showed no damage and no signs of acute kidney failure or injury from rhabdomyolysis from lying on the floor. His WBC level was approximately 13,000, indicating some form of sickness. A CAT scan was performed to test for abnormalities in the patient's brain that could have caused his fainting. The test showed no signs of abnormalities, and a CXR test was performed to check for pneumonitis. The test showed inflammation and fluid in both lungs, and he was diagnosed with a severe case of pneumonia. 4 days later, inflammation in the lungs caused breathing to collapse and apnea to form. He then required medical ventilation by PEEP, which then ruptured the lung alveoli. The air was then trapped inside the pneumothorax, thus treated by a tracheostomy breathing apparatus to prepare for long-term ventilation requirement, and he was deeply sedated as a case of ARDS was formed. The next day, a thoracentesis was performed, and fortunately the fluid was removed from his lungs. After 2 weeks in the hospital, the absence of fluid in the patient's lungs was sustained by the body, and the sedation was stopped. The antibiotics treated the pneumonia, and after another 2 weeks, the tracheostomy tube was removed.